Welcome back. We've had a wonderful discussion so far. We have a lot of material still to cover. Our next panel will discuss topics that have come up actually already today, having to do with data and the challenges of conducting research in the area of disability. To moderate that panel, I'm going to turn it over to Dr. Lisa Iazzoni, who you have met, professor of medicine, Harvard Medical School, one of our theme advisors. Lisa, over to you.
Thanks, Alan. I'm really happy to be here today hosting this panel. I'll briefly introduce all of the speakers at the top, and then after finishing their talk, the next panelist will speak.
We've had a wonderful discussion so far.
As Javier said, for more information about these accomplished contributors, you can find full bios of the group on the event webpage at healthaffairs.org. So our first presenter is Williane de Cormier-Ploski, Program Manager for the Multi-Regional Clinical Trials Center at Brigham and Women's Hospital and Harvard Medical School. Jean Hall is up next, Director of the Institute for Health and Disability Policy Studies at the University of Kansas, followed by Julie Weeks, Chief of the Measures Research and Evaluation Branch of the Division of Analysis and Epidemiology at the CDC's National Center for Health Statistics. So Dr. de Cormier-Ploski.
Thank you. Thank you, Dr. Iazzoni. Can you see me now on the screen?
Yes.
I don't see my slides yet, though. Next slide, please. Thank you. Oh, sorry, previous slide. Thank you. So thank you for the opportunity to present here today. I am Williane de Cormier-Ploski. I'm a program manager at the MRCT Center of Brigham and Women's Hospital and Harvard. I have brown hair and brown eyes, and I am wearing glasses today. I am presenting on behalf of my illustrious co-authors, Ari Neeman, Benjamin C. Silverman, David H. Strauss, Leslie P. Francis, Michael Ashley Stein, and Barbara E. Buehrer. I'm presenting on our paper, Excluding People with Disabilities from Clinical Research, Eligibility Criteria, Lack Clarity, and Justification. Next slide, please. So I thought I would start by introducing a little bit of background about what clinical trials are. Clinical trials are designed to test and evaluate the safety, efficacy, and effectiveness of drugs, therapies, vaccines, devices, and other interventions. They go through several phases. Phase 1 is the appropriate dosage and safety testing. They progress onto phases 2 and 3, which test efficacy and safety in a limited number of people, and then into a broader number of people. For people who participate in clinical trials, the clinical research can offer benefits, including access to diagnostic, preventative, and therapeutic interventions that are not otherwise available. Next slide, please. So why focus on eligibility criteria, and what are eligibility criteria? As you've heard previously, and you will hear in the forthcoming presentations, data accessibility on the representation of people with disabilities and data standardization is not great. So one of the ways we were trying to look at the question of if people with disabilities were included in clinical research, and if not, how they were excluded, was to try and access that information through the eligibility criteria and clinical trial protocols. So each study protocol describes the study's research objectives, the eligibility criteria, the design, the procedures, the data collection and analysis, the informed consent process, and also the benefits, risks, and burdens of the study. So within the eligibility criteria, it's made up of 2 sections. One is the inclusion criteria, which are the characteristics necessary for inclusion. And then you have the flip side, which are the exclusion criteria, and it describes characteristics that disqualify participants from joining the study. Next slide, please. So our study methods included quantitative and qualitative analysis. We reviewed 97 study protocols from clinicaltrials.gov. We restricted our search to phase 3 studies with at least one US site. We also only included studies that focused on adult and or older adult participants and recent studies from the years 2015 to 2021, so we could kind of capture recent developments in disability guidance. We focused on 4 therapeutic areas of dementia, depression, diabetes, and lung cancer, and we selected these so that we could have what we felt to be the most diverse cross-section of eligibility criteria to evaluate. Based on the literature and expert guidance, we looked particularly in the eligibility criteria to code for 10 different disability-related domains. You can see these on your screen. They're cognitive, psychiatric, substance use disorder, visual, hearing, speech and communication, mobility, HIV or hepatitis, long-term care setting, and then we used other chronic condition for any disability-related conditions that didn't fit in any of the other categories. And what we did is we coded for exclusion within any of these disability-related domains. So for example, for visual disability-related domains, if the study said a very broad specification to say something like excludes people with visual impairment or visual disability, or if the study had a diagnosis that applied to some or all people within that, that disability-related domain, such as for visual macular degeneration. Next slide, please. So this is an example of one of the exhibits in our paper. This exhibit 3 is the % of study protocols with eligibility criteria, potentially precluding people with disabilities from clinical trials. You can see on the right-hand side, forgive me, the chart is a little small, but you can see that a large number of studies did have language that would potentially preclude people with disabilities from participation in clinical trials. And you can see that particularly with the disability domains of cognitive, psychiatric, substance abuse, HIV or hepatitis, and other chronic conditions, where 50% or more of the studies had these exclusionary statements. Next slide, please. So we also wanted to show some examples of some of the qualitative piece where we had investigator discretion and exclusion justification statements. Many of the study protocols had investigator discretion statements. Just 2 examples here. One of them is, in the investigator's opinion, participants are well motivated and capable. In another example, it would say, is judged by the investigator to be inappropriate for the study. You can see that these are very broad statements. Few of the studies included justifications for their exclusions. I'm just going to mention one here. One of the justifications said, patients with psychiatric or other listed conditions that, according to the investigator, will preclude their safe participation in this study or will make implementation of the protocol or interpretation of the study results difficult. You can see this is very broad, and I think it speaks to some of the things that previous presenters have mentioned, such as what Dr. Iazzoni and Dr. Meeks mentioned if you combine this with ableist attitudes and erroneous assumptions, how this could be problematic. And also what Tara Legu said, where she had said, and I'm going to steal her line, while some excuses were possibly discriminatory, it is also difficult to identify intent. Next slide, please. So I just wanted to conclude by saying that the exclusion of people with disabilities from clinical research without appropriate justification is discriminatory, is counter to federal regulations and research guidelines, and it limits study generalizability. Next slide, please. Thank you very much for the opportunity to be here.
I guess I'm up next. This is Jean Hall. My team's paper focused on comparing measures of functional difficulty with self-identified disability and implications for health policy. I'd like to acknowledge my co-authors, Noel Kurth, Catherine Ibsen, Andrew Myers, and Kelsey Goddard, as well as acknowledge funding from the National Institute on Disability, Independent Living, and Rehabilitation Research. Next slide, please. A little bit of background. Documenting Americans with disabilities is essential for allocating sufficient resources and programs to meet their needs. Equally important is understanding the types of disabilities experienced so that resources and programs can be tailored appropriately and health disparities can be addressed. After the Affordable Care Act, most federal surveys use the 6-question set from the American Community Survey, or the ACS-6, to identify respondents with a disability. Some use the Washington Group Short Set, or WGSS. Both of these question sets assess functional or activity difficulties, but do not identify specific disability types. Both of these question sets have been shown to undercount some groups and overcount those with transitory disabilities. Next slide, please. So to address these issues, we use data from the National Survey on Health and Disability to compare self-identified disabilities with ACS-6 and WGSS responses. The NSHD had a sample of 2,164 people with self-identified long-term disabilities affecting their life activities. We use these data to assess rates of 2 types of false negatives using the ACS-6 and WGSS. First, we looked at full false negatives, which occurred when no disability was endorsed by a person with a known disability to either the ACS-6 or WGSS questions. We also looked at partial false negatives, which occurred when a person's main disability type was not endorsed among the ACS-6 or WGSS questions. For example, a person identified their primary disability as a mobility disability, but only answered yes to a seeing or hearing question. So results for the ACS-6, the overall full false negative rate was 19.5%. This says that approximately 1 in 5 people with known self-identified disabilities would not have been identified as having a disability by the ACS-6 questions. Those who self-categorized their disability as a chronic illness had the highest false negative rate at 31.6%, followed by those with mental illness or a psychiatric condition at 22.7%. When we looked at the WGSS, the full false negative rate was even higher at 43.1%. Those who self-categorized with a mental illness or psychiatric condition had the highest full false negative rate at 58.7%, followed by those with chronic illness, which indicates that the WGSS is missing more than half of people with these conditions. Partial false negatives were also prevalent. For example, 22% of people self-categorizing their primary disability as a physical or mobility disability did not endorse the ACS-6 ambulatory question, and 37.7% did not endorse the WGSS ambulatory question. In these instances, a respondent would be identified as having a disability, but the functional area identified would not reflect their self-reported primary disability type. Next slide, please. So what are the implications of this research? Many people with disabilities are being missed by the ACS-6 and WGSS measures currently used in federal surveys, especially those with mental illnesses and chronic illnesses. As others have noted, funding for these groups may be inappropriately low, and effects of the pandemic may be especially underestimated. If we don't know which people have disabilities, then we don't know their experiences with the pandemic, but it looks like they were not good. Those in the growing population of people with long COVID may be missed in the future, again, resulting in inadequate resource allocation. We know that people with long COVID often experience psychiatric types of conditions or chronic illness types of conditions, and based on our research, we would think that they would be likely to be missed. So we recommend specific questions to consider in future surveys, including a broad question regarding presence of a condition affecting life activities, a disability categorization question, and a question to assess age of onset or duration of disability. And I'm happy to talk about this more because I think there's some questions out there. Thank you.
Thanks, Jean. It's a pleasure to be part of today's symposium. I'm Julie Weeks, and I'd like to acknowledge my co-authors, Dan Mott, Jennifer Maddens, and Heidi Ullman. We are honored to have our paper on harmonizing disability data included in the Health Affairs special issue. Next slide, please. I think we have heard all day, so I'm not going to take any time to discuss why it's important to collect disability data. The bottom line, however, is that when we fail to collect information on disability, people with disabilities remain invisible. It's also important to remember that we have a number of treaties, civil rights laws, and policies serving as federal and international commitments that exist to promote and protect the rights of people with disabilities. And without exception, these provide strong and compelling arguments, indeed obligations, for the collection, disaggregation, and dissemination of data on disability. Most recently, the need for data and the acknowledgement that equity cannot be achieved without it is embedded in President Biden's 2021 executive order on advancing equity. Despite all of these commitments, the collection of data on disability is neither universal or consistent across data collections, and addressing this is a matter of equity. Next slide, please. We must begin to move beyond talking about collecting data on disability to start talking about harmonization of disability data. To be fair, disability data are collected in many and different types of our collections. We have it in the US Census, in federal and non-federal surveys, and where there is a programmatic need in a handful of administrative data systems. The problem is that not all collections include data disability items, and as importantly, when they do, a standard set of items is not used. This leads to inconsistent and confusing results and ultimately distrust of the estimates. But equally important is the missed opportunity to combine data from different sources and utilize that much richer understanding of functioning and disability, not only to develop effective and targeted policies, but to monitor, evaluate, and if needed, change these policies to better serve those with disabilities. A common core of disability questions on all data collections would improve comparability, as well as our national discourse about disability programs and policy. Next slide, please. What's needed to accomplish harmonization is a bridge. That is placing a standard set of well-validated questions across all types of data collections. This would provide us with powerful analytic capabilities. One could crosswalk the same types of data collections, for example, population-based surveys, or across different types of collections. A population-based survey, for example, linked to an administrative data source. Data can be compared across different federal entities, such as combining health information with housing or justice statistics collected at a different agency. And ideally, the right question can be used as a bridge between the US and other countries. Each of these capabilities expands our understanding of functioning, disability, what works and what doesn't when it comes to full inclusion. Next slide, please. Our recommended bridge is the Washington Group short set on functioning. The short set was developed, tested, and adopted for use as the international standard for collecting disability data in 2006. The Washington Group on Disability Statistics was formed in 2001 as a United Nations group tasked with improving the state of disability statistics. That is, addressing both the lack of data as well as the varying methodologies that have historically been employed. The short set asks about difficulties in 6 basic domains of functioning, and it was designed to align with both the social model of disability as well as place measurements specifically in the area of functioning that is consistent with the ICF. Moreover, the short set acknowledges, that disability is a continuum. It's not a yes-no dichotomy. So the response options collect the full range of difficulties in functioning from no difficulty to cannot do it all. Since its adoption, over 100 countries have included the short set in their data collections, and the US is no exception. The short set is included in data collections at the Census Bureau, at the National Center for Health Statistics, and is being tested or considered for inclusion in surveys at a handful of other federal agencies. Finally, the short set can be added to. It is embedded in longer question sets developed by the Washington group, including questions that include questions on psychosocial functioning, such as anxiety and depression, pain and fatigue. And there are questions designed for children specifically that include important domains of functioning that are age appropriate for children. Next slide, please. In sum, harmonizing disability data is an important next step to ensuring that we have meaningful data to guide us. It means placing a core set in all data collections and considering as much variety in the types of collections as possible. It does not mean that we have to stop there. We can add questions, and it does not mean that eligibility for program benefits or for legal statuses must change. Rather, harmonization builds trust, will expand our knowledge, and improve our policies aimed at full and equitable inclusion. Next slide, please. Thank you so much. Over to Lisa.
Thank you. All right, and thanks to the presenters who not only gave great presentations, but did so in a totally timely way. So we have as much time for questions as we have. And Jean, I want to go first to you. I've been working in Massachusetts on some various policy committees about adding disability to the standard kind of data set that our state collects for looking at healthcare quality and disparities. There's tremendous resistance about the money that it will cost to do this type of data collection. You suggest in your paper adding 3 questions to what are already 6 questions about disability. So I wonder if you could just address some of the practical consequences of adding this many questions to kind of standard administrative data sets or public health surveillance systems.
Sure, Lisa. I guess I would make a couple of points. The first would be that I would argue we can't afford not to add these questions or something like them. The disability population is large and growing, as you know. As a group, they use federal programs at substantially greater rates than people without disabilities, especially when you look at the intersection of disability and poverty. So federal surveys are supposed to help us understand population needs and effectiveness of programs. It's not acceptable to collect data that don't provide evidence to support effective decision-making. And I would also add that technically we're only recommending adding 1 question with 2 follow-ups. So we'll ask a question about a broad disability, and if people say no to that, that's the end of the question. If they say yes, then there are 2 follow-up questions. So for the majority of people, it would only be 1 added question.
Okay, thank you. Dr. Ducomier-Plosky, I thought what you and your colleagues did was just so clever, going to clinicaltrials.gov and looking the way that you did. And you kind of commented on this in your presentation, but we've already had a number of comments throughout this afternoon about the stigmatized attitudes of healthcare professionals about people with disabilities. And given that they are the people who determine inclusions and exclusions for the studies, how would you train researchers and institutional review boards to not be ableist in conducting these studies?
Thank you, Dr. Iazzoni. That's a great question. I think it's a multi-part answer and some that we've talked about already. One of the, I think, key points is to include people with disabilities from the outset in undergraduate all the way through graduate training. Make sure that they have opportunities through different pipelines, cohort hiring, everything we've mentioned, non-discrimination in hiring, so that you have representative people who can speak to, to these issues on IRBs, within the medical research communities and within the people who interact with patients. Secondly, I think that we've spoken about this before, but encouraging respectful language. And I love that you had in your presentation, ask, that's just always such a key point, ask and listen. Thirdly, I think, providing information. This publication has been, I think, a wonderful addition to the literature, but also trying to provide tools that are operational for IRBs that they can tangibly take. We can show them examples of eligibility criteria that are too broadly written, and how those could be adapted, how you can include sections on accommodations, advice not to copy paste eligibility criteria from one study to the next that may not apply to the next study. And that finally, I think just this idea that awareness building isn't just a one-off. It's, a progression throughout time for people throughout their careers, whether it be, even at the high school level, undergraduate. I think sometimes we get the impression that this is something you just get from HR at your job, but it's really, a continual process, and a very important one.
Good, thank you. So, Julie, in 2 minutes, which we have left, in your paper, you talked about the political will, and I asked Jean about the cost of data collection, and you talked about getting the political will to actually make this happen. So could you maybe talk to our audience just a little bit about what you mean by that?
Yes, of course. I think that the most important slide is probably that very first slide where, I think we need to go back and refamiliarize ourselves and utilize those commitments that have been made by our policymakers to collect data, to use the data to eliminate disparities, especially as they are related to disability. When we leverage those, we have very powerful tools and a very powerful voice. I think that we also need to include the population with lived experience in that process. That's a very important step, and I appreciate others who have used that in their answers to the many questions today as well. And finally, I would say that, there's always resistance to the, adding data items to our data collections. There is no excuse, and there are well-tested and validated sets that do minimize the amount of time and cost associated with including them. And we don't hear, and sometimes or don't get resistance from including other items. So why should disability be any different? Thank you.
That's a great way to end. Thank you, Dr. Weeks. Alan, should we take a brief break?
Yes, that is a great way to end. And thank you to our panelists and Lisa for leading us through that panel. For captioning and sign language interpretation reasons, we need to take a short break. It'll just be about 3 minutes long. I assure you in the audience, you don't want to leave. We've got some great content coming up, but we will go silent for 3 minutes to allow for a transition.